Hello, and thank you for joining us today. This webinar features four esteemed healthcare leaders with a passion for meeting the needs of today's patients and communities, particularly those in traditionally underserved communities. Our conversation today will focus on the cumulative factors that have led to care inequities being all too prevalent across our country's healthcare landscape. And we will also discuss steps that hospitals can begin taking now to increase care quality and patient engagement. This is a great panel, an esteemed group, as I mentioned. I'm going to have each of them introduce themselves and share a little bit about their role in organization. Reggie, I'm going to tap on you to get the ball rolling here.
Oh, thanks, Brian. So hello, everyone. I'm Dr. Reggie Eady, President and CEO of Trinity Health in New England. We are a 5-hospital system that spans from mid-Connecticut up to southwest Massachusetts. It's a pleasure to be participating in such a very important conversation. Thanks for having me.
Thanks for being here, Reggie. Dev, why don't you go next?
Hi, good afternoon, everyone. I'm Dev Sangbai, family physician. I'm with the Duke Health System here in Central North Carolina. I've been a part of Duke for 20 years, and my role primarily is in our population health space, and I serve as Vice President for Population Health.
Thank you so much, Dev. And Moo, why don't you round us off here with the intros?
Hey, thanks, Brian. Emu Tomlinson, better known as Moo. I'm the CEO of Vituity, which is a physician partnership. We staff hospitals around the country in emergency medicine, hospitalist medicine, anesthesia, et cetera. I'm also the president of Vituity Cares, which is our nonprofit foundation where we take care of people who would otherwise get left behind by the healthcare system.
Thank you so much, Moo. And we'll start with you on this first question, and I want to hear from everybody on this one, just so folks watching can really get a sense of your perspectives and where you're doing the work that we're talking about today. So the first question, Moo, then is what are the most significant health disparities facing the communities you serve?
Yeah, I think in our communities, we have a predominance in acute care. So, our mindset has been historically to take all comers, and in the emergency department or in the hospital or even in our outpatient settings, we take all comers regardless of payer status, class, where they're at. And what we've seen through the pandemic is that populations have been a little bit resistant to coming into the hospital, not just because of COVID, but because of different factors as far as the money they make, the earnings, they've been laid off, they're concerned about those particular issues. So I think that while we have seen a boon in sort of technology and virtual health and really creative ways to engage patients, I've also seen a lot of patients get left behind. And, as fundamentally as an emergency medicine trained physician, that hurts my heart because, my mindset is take all comers and manage whatever needs to be managed.
And quick follow-up for you, Moo. I think that you made a great point about it's sort of an exciting time as far as technology goes, really being able to reach patients in a different way. But at the same time, we don't want those solutions to sort of maybe further, exacerbate these disparities that have lasted for a long time. How do you think about that? I'm just curious. How do you think about making sure that healthcare is leveraging this, like the awesome technology that's coming about in a way that doesn't sort of progress or add to the inequities that have lasted for so long?
Yeah, so one of the concepts that I want to say that I came up with, but I know I didn't because great ideas are shared amongst us all, is that I feel like we serve in that interface between patients and their health. And so, whether that's in person, whether it's a family doc meeting with somebody in person or meeting online or meeting in the ICU, that we really manage that opportunity to get that patient healthier. And so, one of the things that we struggle with in Vituity is to make sure we see people and then we manage the payer relationships, we manage the hospital relationships to make sure we get paid. But that bothered us. And so that's when we started our Vituity Cares Foundation. And under that organization, what we do is we just take care of people. So we go to unhoused communities, we sit with them, we talk to them, we ask them their names so we can address them, but we don't get any other information because they know they may not trust us, they may not have access to computers or laptops or virtual platforms, and we just go ahead and take care of the people there. And that's, I think, the key with this is to make sure that we remain multifaceted as we start to get increasing technology and increasing ways to engage patients.
Appreciate that. Thank you, Moo. Dev, how about you? Can you talk about the sort of the most significant health disparities that really face the communities you serve?
Yeah, most definitely. Similar to what Moo mentioned, when you provide a service where you take all comers, you're going to get all comers coming to you. And one of the things we've recognized, which has really been heightened by the pandemic, is the significant difference in clinical outcomes that you see among certain populations. And I think we've known that for a long time. As far as back as the three of us probably were in medical school, we remember when we were taught about health disparities and so forth. I think what's different right now is that there's a reality that we really need to do something about it. And we can no longer just say that those are differences in data and we just have to accept those differences in data. And so, for example, when we look at hypertension, we see vulnerable populations have significantly underperformance when it comes to clinical outcomes and keeping blood pressure under control versus other populations. And we're trying to do a better job at understanding exactly why that happens and how we can get to innovative solutions to make it a part of everybody's responsibility. So as an example, we have now instituted a program where if an individual arrives at our clinics with an elevated blood pressure, typically we think of that as maybe a medicine subspecialty or a primary care condition. We have now empowered and asked all of our providers to use the electronic health system, our EPIC system, to identify those patients, even if they're coming in for an orthopedic consultation, for example, that their blood pressure is high, make the referral back to primary care. Because going back to what you asked earlier, the most significant disparity we see is just really how different outcomes are based on race, ethnicity, and even some cases gender.
I appreciate that, Dev, and I look forward to diving into more of the work that you're doing there to sort of really knock down some of these barriers to access to care. Reggie, I want to hear from you now and talk about the most significant health disparities you're coming up against in your work.
Yeah, I mean, I think those my colleagues did a great job. We I think are aligned in thought and largely in activity. So maybe I'll take a slightly different approach in answering your question. If I could pause for a quick moment and just remind the audience of the definition of health disparity, since that's really the question you're asking. And if I remember the definition remotely correctly, these are preventable differences in burdens such as disease, injury, violence, opportunities, I should say, to achieve optimal health and such disadvantaged populations. So when you think of the word disadvantage, we're talking about populations that have unfavorable circumstances, right? And remember, these are preventable, reversible. So my point is that healthcare disparities are driven largely, according to the textbook, by social and economic inequalities. And I would suggest to the audience and leaders across our countries is remember these are reversible. I mean, true leadership can address these, and we can talk about eliminating such disparities. So to answer your question, in the communities that we serve at Trinity Health New England, these include economic stability, education, food insecurities, community safety, gun violence. Those are huge. And I guess I'd wrap it up by saying, or reminding the audience that while the textbook says that healthcare disparities or health disparities are caused by many factors, including genetics, access to care, which we're going to talk about more of, I'm sure, in the conversation, poor quality of care, there's one fact that I would like the audience to keep in mind, and that is that 60% of one's health is determined solely by one's zip code. 60% of the outcome of one's health is determined by one zip code. To me, that tells the story, Brian, and it underscores the fact that these healthcare disparities, although they are real, they're preventable, reversible, and there's something that can be done very quickly about them all.
Reggie, I really appreciate that point around the preventability, right? But when we have these conversations about health disparities and health inequities, it can feel like it is a vast problem, but it can feel so big that it's hard to imagine putting your arms around it. But as to your point, it can be done. They are preventable. These are things that can be solved. These are problems that can be solved. So Reggie, I want to start with you on the next question to dig in to hear about how you're doing this work. What does your organization do to address barriers to care access specifically, and anything else you'd like to share about the work you're doing?
Yeah, so I guess I'll start by suggesting that we're following the data, and most importantly, we're surveying the communities to better understand how they want us to address their experience barriers. So, it's my opinion, Brian, that for far too long, we as healthcare leaders have made such decisions in isolations of the communities that we serve, which is a huge mistake. For example, I just flashed back to April, May of 2020, during the first wave of the pandemic, when COVID testing, I would describe as being paramount, right? That was really what we were focused on during the first wave of the pandemic. And so, look, Trinity Health in New England has a Black male as its CEO. And I wanted to be one of the first to get out there and open up a drive-through testing. So we led the state in doing so. That is the state of Connecticut. We were also comfortable. And so this is the vulnerability I'm about to expose the audience to, my vulnerability. So we proudly and comfortably announced that we would that was mistake number one. Next, we proudly and comfortably announced that one had to be in a vehicle to come through this drive-through testing. This is mistake number two, because if you think about it, just like in the state of Connecticut, about a third of the residents in this country don't own vehicles, right? So that's mistake number two. And then we thought we were doing something when we created a walkthrough line, but mistake number three, Brian, was not remembering or realizing that the average American lives at least 10 miles away from the nearest hospital. And so what does that do to the elderly or the handicapped, right? We weren't thinking because we didn't go to the community, and this is the point I'm trying to make. Instead of us deciding what's best for the community, let the community tell us what's best for them, tell us and teach us how to serve them. So we sort of hit Control Alt Delete and began having conversations with the community to better understand how we can better serve them. By the time the vaccine became available, I'd suggest we got it right. So we hosted a 24-hour Vaxathon in the heart of one of our most disadvantaged communities. And I'll just end with this one testimony. We heard from an essential worker who actually had two jobs, and she worked in the morning, throughout the afternoon, had a small break, and then had to go to her second job in the evening. And she explained that by the time she either got off work or was going to work, the vaccination centers were either not available because they were closed, they were too crowded. And so she didn't have access, right? She did not have access to the vaccine. But she told me face to face that because of the Vaxathon, not only was she able to get vaccinated because it was a 24-hour operation, but her friends and families from her community were also able to get vaccinated. And by the way, that's, I think, an idea or a good example of demonstrating equity versus equality. Thanks.
Appreciate that, Reggie. And to your point about sort of laying out those mistakes, as you call them, I think that's what it's going to take for a lot of folks to make a difference, is to own it and be like, hey, we didn't get this right. Let's try this again. Let's try something different, right? Like, you've got to be able to, the phrase you use, hit Control Alt Delete on a few things, right?
That's right. Yep. Thank you for that.
Absolutely. Dev, same question to you. How are you working to address barriers to care access?
Yeah, it's a great question. And really, to piggyback on what Reggie mentioned, the first step in addressing barriers is really understanding what those barriers are. So we've put considerable effort in really understanding what those challenges are that don't allow individuals to access the healthcare system. And we, again, here too, there are some things you just know are going to be a challenge, cost, insurance, and those sorts of things. But it's also those things, those social drivers of health, really getting good data on exactly what those social drivers are that are making it challenging for individuals to access healthcare. And I think the point that Reggie made is a great one. You got to go deep into the community at the zip code level, at other levels, because I think if you look at it too high of a geographic level, you just make some assumptions that aren't going to apply to every pocket of the communities that you serve. So we've spent considerable time doing exactly the same, understanding at a zip code level where we have access issues, particularly around those social drivers of health, and then working with the community, and whether it's community benefit organizations, even government, to understand what can we do to overcome some of those barriers. As you might imagine, it's not easy because many of these things aren't instantly solvable. I think we talk about food insecurity, and there are ways to maybe temporarily solve that issue. We talk about transportation, and we know there are ways to meet that. But when you get into things like housing, which in some ways is being identified as probably the most critical social driver of health in some ways probably connected to zip code, becomes much more challenging, I think, for a hospital or health system to figure out where they can exert the best influence to be successful. I know later we're going to talk about what gives us hope about this whole process. That's actually what gives me a lot of hope. That we're at a point now where finally recognizing that the healthcare system can do something about these things that historically we've said, well, it's a housing issue. I'm a healthcare provider. I'm not exactly sure what I can do, or it's a transportation issue and so forth. It's not going to be solved entirely by the healthcare system, but I think we're asking for a seat at the table, which really is exciting.
Can you share a little bit more about that? The sort of like asking for that seat at the table around these housing issues, which are just so huge and pervasive across the country, right? In various zip codes, it's a massive, long, like generational issues that contribute to housing issues in this country. Where do you is it community partnerships? What is asking for the seat at the table? What table? Just get into some specifics.
That's a really good question. I think it's an all hands on deck type of approach, because when you look at challenges that are really identified through social drivers of health, to go back to what I said earlier, it really is everyone's responsibility. So understanding to the extent that there are opportunities to improve housing within the community, what's happening with respect to just the growth of housing in our particular part of the country, and I'm sure it's true just about everywhere else. The housing market is incredibly strong, and so it really makes it complicated when individuals are trying to secure good, healthy housing. But it's also this idea that when individuals are able to find themselves in a situation where housing may not be the most important social driver, still being able to access healthcare. One of the things that we've been doing for a long time period is in some of our more concentrated areas is actually sending healthcare providers into those communities, into these housing centers where you may have a high density of population that uses your services, to provide check-in appointments, not to take away from the primary care provider or any other healthcare provider, but understand what's happening to patients in between visits.
Thank you so much for digging in there and sharing a little bit more details there, Dev. Mu, I want to invite you, of course, to share any hook-ons you hear so far based on Dev's comments and Reggie's comments. But I also have another question I want to get to with you as well. But any additional comments right now?
Yeah, I appreciate it, Brian. I'm so inspired. I know this is for other people to consume, but I'm listening to Dr. Edie and Dev and what you all are doing, and I get inspired. And if you don't mind, I want to share a little bit of what we're doing. I think, if you look at healthcare, it was created for providers. And when I say providers, hospitals, systems, physicians, PAs, et cetera, right? I mean, we create models that make hospitals and providers more efficient. And if you look at where we ought to go to a model where we make it more efficient for the person, for the individual. You don't even call them patients, right? There's so many health issues that aren't healthcare. And so I think that we have an opportunity for that model. We call it health in place. You could call it, health at you, but wherever the person is, we want to go and help them get healthier. We want to help them feel better, look better, act better, and the gamut of all those things that make us who we are. I think the key to that is provider engagement. And so if you look at it, we create structures that we all learned back in medical school on how to care for patients appropriately, but we need to blow all those up. We need to engage in chaotic and disruptive ways where we're uncomfortable, because it ain't about us, right? And that's, I think, really the model. Lastly, DEI, right? We all talk about the costs of DEI programs and hiring people, and do the costs outweigh the benefits? We engaged in DEI because we believe that if we don't have the right providers that can go, Dev, into those neighborhoods and really generate trust and engender trust with those individuals, then how are people going to feel comfortable talking about their hypertensive tension, or talking about the headache they've had for 3 months, or talking about the fact that they don't want to live anymore? You really need to get people at the line level who breathe, understand those communities, And lastly, I lost some points on this in my organization through the generation of our Vitality Cares Foundation. I wanted to create a model where we don't even worry about pay. I wanted to look at, can we get into those unhoused communities, can we work with food insecurity and housing insecurity and violence insecurity, as you said, Dr. Edie, and really go into those communities and just talk to them and help guide them. Now we want to put them in places where they can receive long-term care and long-term opportunities for with other providers, but sometimes just having that voice to sit down and talk to them about the things they're scared about, makes a world of difference.
Thank you, Moo. And your comments there around trust and getting the right sort of personnel in place to be able to establish that trust in the community gets me exactly to where I wanted to go with the next question. And I'll put it to you, and maybe you can dive in a little bit deeper here. Can you talk about how you're leveraging provider teams to increase and rebuild patient trust in a lot of cases?
Yeah, I think that's a really tough one that we're all, tackling with from different sides of the coin. I'll give a quick personal story, if you don't mind, about my personal household. And don't let her know that I told you this, but my mother-in-law didn't want to get vaccinated. And just so you know, my wife is a family physician and I'm an emergency physician and the CEO of a big healthcare organization. I was a little nervous that somebody was going to find out my mother-in-law was not getting vaccinated, but she was scared. I mean, even though she had two providers in the house that could talk to her and educate her and show her, she had a long-standing fear. She's about 78, so you know what time she went through. She's very fearful of the healthcare landscape, and so from that standpoint, I think the best way to dive in is sort of what we said before: is make sure that you're engaging people the way they want to be engaged. And that's very hard for healthcare systems and for providers. And as we get together and talk about contracts and talk about payer contracts and we talk about risks, we always have to say, well, what's best for the people that are going to work to get this healthcare? I think that's really the key.
I appreciate you sharing that, Moo. And it's sort of like when you're having conversations with folks, like people's fears aren't necessarily invalid just because they might not be accurate. Like you have to validate them and have you engage with them the way they need to be engaged, I think is how you put it, right?
Absolutely. There's a line I like to use. It's healthcare that people want on their terms. And their terms, we talk about healthcare at home. I struggle with that concept. I know it's something that's sort of taken off in all industries. I struggle with that because there's sort of healthcare at work. There's healthcare, for the home, for the unhoused. There's healthcare in the shopping mall. There's healthcare all over the place. And so I totally agree. To build that trust and really talk to people and work with people on their terms. And it may mean that we really need to look at providers and hospitals in new ways, in very new constructs for us. And I just want to reiterate, it's going to cost us money. And it's going to decrease in the short-term margin, but in the long term, it will absolutely benefit hospital systems and providers to take care of populations in this way.
Appreciate that. Dev, I want to turn to you on the same question, which is, how are you working around, building or increasing, rebuilding patient trust?
Yeah, I think Moo hit the nail right on the head. Part of it is like you said, it's building trust, going into the communities with the right representation of your health system, individuals who are from those very communities who can really, who can build that trust, and understanding what the community wants and needs. We're part of an academic medical system, so we do a lot of inquiry and probably can look at data in ways to understand, hey, what might make sense? But what might make sense from an academic perspective may have no bearing on what makes sense from the community perspective. So finding a way to go into those communities and understanding what makes sense to them. The other thing is I think Moo's point was a really good one. It's going to cost. I'd say be prepared. We may have to actually redesign the bricks and mortars kind of elements that we have in healthcare because we designed them one way for, I think, as Moo said it, or maybe in Reggie, to me, provider-centric. How do you make it patient-centric? And so we're actually exploring things like labor and delivery. We've designed labor and delivery that maybe made sense from a scientific perspective, maybe from an operational perspective. But when you think about a community perspective and an equity perspective, is it really designed the right way?
Appreciate that, Dev. And Reggie, I want to get to you on another question in just a second. But Dev, can I ask you a follow-up and just like perhaps how technology factors in here for you, and how you're leveraging technology to increase access to care and address these issues. I would like to hear that from you quickly before we move to Reggie.
Yeah, again, that's a great question. I think all of us can talk about the leaps and bounds that we've made in telehealth ever since COVID. And I think many of us are now providing services that if you'd asked us 2 or 2.5 years ago, would you be able to do via digital platform, we would have said no, and we're able to do that. So that continues to be something we focus on, recognizing that there's a huge digital divide, and you just can't say, telehealth is the way to go when there's access issues, both in terms of broadband and hardware and all the other things that you need to be able to do that. But we're also looking at technology from a remote monitoring perspective. What can we use with remote monitoring that would then help us understand what's happening to our patients when they're in their homes and their communities a little bit more? Admittedly, it's a little bit difficult because even under those circumstances, you can be met with the same challenges related to hardware, access, broadband, and so forth. There's another piece that we've looked to, which is trying to understand how provider to provider communication can leverage technology a little bit better. So we know that in primary care, sometimes we have to refer patients to a specialist, but maybe a 5 or 10-minute conversation with the specialist is all that we need. And we don't need to have the patient route through the regular process of making an appointment and go through all of that. So we've set up a system where we can have mostly primary care providers, but others have electronic consults with specialists within our system for those quick and easy things that are outside of the scope of the primary care provider, but don't require a full traditional referral. What that does is it saves money, it saves time, creates capacity in the health system as well. So we're also looking at ways we can get providers better engaged in what we're trying to achieve in this dialogue that we're having.
Thanks, Deb. Reggie, any hook-ons there? Any additional comments before I pose another question to you?
Yeah, sure. I think like other healthcare systems across the country, we also at Trinity Health leverage telehealth. I mean, we didn't have such offerings in a lot of our markets, and all of a sudden, almost overnight, we did. But what's interesting, if I got the statistic right, or the most recent statistic I recall reading, was only about 25% of Americans utilize a modality in the broadest sense, right? So audio, visual, audio only, chat, etc. 25%. Now remember, this was, and Moore would appreciate this as an ED doc, like I am, the emergency department campaign across the country was stay at home. We come to work so you don't have to come to the hospital. And I scratch my head about that. And then you look at only 25% of Americans who we told to stay at home use this alternative modality. That's pretty scary. What about the other 75% of the people? What were they doing? So I think it just really still underscores the fact that we've got to meet people where they are, and we have to ask them what works versus deciding ourselves as leaders, because we think we know best all the time what's best for the community, especially the most vulnerable communities.
Thank you, Reggie. And the question I want to ask next, which is, we sort of talked about earlier, like the breadth, the scope of some of these problems that can be addressed by healthcare, but not only addressed by healthcare. So the question I want to ask, and Reggie, we'll start with you, is what impacts do public policy laws really have on your efforts to deliver equitable care? And what messages would you like to send to policymakers?
Yeah, so it seems like at least in New England, I have been having a number of conversations about this very topic. I'm curious if that's exactly why this question was directed toward me. So it's germane. So first of all, let me say this: as we talk about equality and equity, I think we should also consider the providers that care. And again, I'm sure both of my colleagues could attest to this: the providers that care for the disadvantaged populations. Why? Because they too are often disadvantaged, right? So what I say to policymakers on a regular basis when we address equality is, let's make sure that you focus in on those disadvantaged communities, but remember those disadvantaged communities are also coupled with disadvantaged providers. So we need to have a more global or comprehensive conversation around that. I will also remind policymakers whenever given the opportunity and where applicable, that they should look more closely at price transparency, as well as anti-tiering, anti-steering, and especially monopolistic behaviors. Because what's happening is these mammoth of organizations that don't necessarily focus on the vulnerable populations, They have higher reimbursement. They sometimes don't have as good quality. They're driving up the cost of healthcare and further marginalizing those communities and those providers in that disadvantaged bucket, if you will. So this needs to be addressed across the country, starting in Washington, D.C., but also in each state. It must be addressed because we're going to look up and find ourselves in a tough predicament as a country from a healthcare perspective, while we currently enjoy having the most advanced and modernized healthcare system on the planet.
Appreciate that, Reggie. Moo, do you have anything to add on to Reggie's comments there?
Yeah, talk about politics. How long did we have this scheduled for? But I think, Reggie's comments are right on point. A little different tact for me. I think we have gotten conversations, fortunately, with policymakers, and they've asked us, or we've, through other parties have been asked our opinion, but that's rare. And I think if I were to ask policymakers anything, it's let's go to where the work is happening to get the advice of those doing the work, rather than sort of arguing on a really high level scale that really doesn't get to where the people need that care. And then secondly, which is a little bit controversial, I kind of think we don't need them. Right now, after this conversation, I feel like I need to call Dev and I need to call Reggie, and we need to work on how to create those models within the environment, the current policies that exist, because we can in some ways insulate ourselves from them if we give up on our own individual goals. So our conversation that we have with our hospital partners and other partners that we work with is, how can we help you do what you need to do, rather than how much money am I going to make? What's the contract look like? What payer makes? Like, those are the typical questions that I think providers get into because they feel like they're in a firefight. But if you sort of give up on that and you realize it's not about me, it's about us and it's about them, then the conversation with all of us is really about what can we do best for patients. And I firmly believe, I've been doing this CEO job for about 5 years. So I'm starting to get my feet wet a little bit. And what I realize is, when you do the right thing, you actually make the money you need to continue to do the right thing. It's an infinite game. It doesn't stop. And so people kind of think, oh, we need to make this money for this quarter. But if you make this money for this quarter so you can help the people, so you can get money for next quarter, it'll all work out if you care for people. And I think that's what the policymakers kind of forget when it comes to payers and it comes to providers, that we're out there doing the work and we know what needs to be done.
Appreciate that, Moo. Dev, I want to give you a chance to speak to this too before I move on.
Sure. Generically at a very high level, whether you're talking federal, state, or even local politics, what we're trying to do here is going to take resources. And I think there needs to be some level of recognition that resources are constrained, that they're going to have to be trade-offs, but this is not going to be able to be solved, at least initially, with the same amount of resources that are available, and certainly not with less. The other is really this idea of fostering and supporting innovation at the local level. Getting back to some of what we talked about earlier, solutions are really going to be derived from the communities, by the communities, and giving them the resources to be able to do what can be done is going to be critical. Oftentimes these things are incredibly innovative. We haven't even thought about what that might look like in terms of where people can get care, how they can get care, and so forth. But if you had to roll that up to a centralized policy level, unfortunately, that gets diluted at times. And so maybe what I'm saying here is it's not a one size fits all. So to the extent that we're looking for policy to help guide us along the way, a one size fits all is not going to work. We really need to figure out how to foster innovation, particular innovation at the local level.
Yeah, I think that's a theme throughout this conversation is, if the policymakers are having a high level conversation and you all are trying to do the work at the zip code level, and Moo, to your point, they need to come to you where you're doing the work. Stuff is going to get missed. I want to move back now to something, Moo, that you talked about around the question around building trust with the community, building trust with patients. And a part of that is really, you mentioned, is really having the right providers, the right staff that can do that work, that can get out in the community and build trust with folks. So I want to ask that, that your staff has to be reflective of the communities you serve. So the question then I want to ask, Moo, is what steps is your organization taking to really increase diversity across your provider teams?
Absolutely. I thank you for that question. I think it's one that I think is a little bit tough to solve as you think about it. And so we've gotten really down to the grassroots on this. So I just wanted to self-declare. I'm African American, but I'm born in Canada, so I'm also an immigrant. And so, you think when I went to New York to start my training, I didn't know a lot. I didn't know how to become a physician. I knew I wanted to become a physician. I knew that I kind of had to do some sciences and stuff like that, but I didn't really have anybody to take me and say, this is what you need to do, and this is where you need to go to be the best provider you can be. And so that's really what we're doing at the grassroots level. Mentorship, really going out there, going to those communities, finding individuals who not even do well in sciences, just really going out there and saying, do you want to care for people? And then supporting them in any way they can. So I think there's multiple levels to that. You want to sort of grassroots mentor those individuals in the communities, especially kids, where we've taken through Vituity Cares, we've taken a kid that would have gone through a school in a not so great school district and provided them a scholarship to go to a private school where they can then change the trajectory of their lives, all the way up to mentorship within the organization. You think you come in the organization and you're a middle manager, or you just started in the organization, to make sure we mentor and foster those individuals so that then we have a bigger pool to choose from when it's time to select physicians that are going to go out to people's homes and care for them. And also, I'm inspired by this panel partly because I see other individuals that may have similar experiences to me. And so that's where I think we need to engage on a level that we've never done before. Reggie's going to go do his work. Dev's going to go do his work. I'm going to go do my work. And we tend to get caught up and forget. But those opportunities to collaborate and get together and just say, hey, what are you doing about this? And then they can say, oh, well, this is what I did. And I'm like, wow, I never thought of that. That sort of level of mentorship, which is sort of peer-to-peer, is not something we do well. So what I really think the key is really mentoring and communicating across the board to elevate so that we have a bigger pool of people to choose from. If we just focus on the choosing, we probably aren't going to get that right. Although you do need, sort of the healthcare Rooney Rule and all those kind of things. You need to create that base of people who can go out there and then we can choose them to care for the people that have similar experiences to them.
Yeah, really hearing a few things there. One, like you just having immediate engagement with folks, talking about it, mentorship, but also a long-term investment of sorts, right? To really start the problem requires immediate action, but won't necessarily be solved overnight. So you got to make those long-term investments too.
Absolutely. The worst thing in the world you can do in your organization is to try to develop an ROI for any diversity, equity, inclusion product, and that's typically, we deal in numbers and our CFOs come knocking on our door. I would encourage you, an employee, to all decide to spend a significant amount of your margin or your cost, for that matter, on these type of programs to make sure that we can get to the future. Because in the future, if you manage your populations well, if you take care of patients well, your overall costs will be lower, and that gives you the margin to then continue on into the future.
Appreciate that, Mo. Reggie, I'll throw it to you now.
Oh yeah, sure. So there are many reasons why I am proud to be a leader inside of Trinity Health in New England. But one that really stands out was the response in the midst of the pandemic. So when the pandemic started, we're all very distracted by this virus that we know little about. We're seeing people die. We're starting to realize a shortage of colleagues. But Trinity Health and its leadership, there was intentionality around their efforts as it related to increasing diversity, as if we weren't in the midst of a pandemic. And it started from the top. So for example, the Trinity Health Board and our CEO, Mike Slabowski, have an expectations that we begin to demonstrate as such at our hospital board level and at our leadership team level. In fact, I have been here at Trinity Health New England as the CEO for 4 years. And one of my first assignments given to me by my boss, Ben Carter, was your board does not reflect the community that you serve. So here's a new guy who's coming from a total different state, new to New England. And I've got to sit down with men and women who populated this board for many, many years. But he was absolutely right. I mean, there was not gender representation, nor was there representation of color. And so having that as one of your first tasks and the support that I received from the leadership at Trinity Health was huge. And so today our board is, it reflects very closely to the communities that we serve. We've got a number of women, we've got a number of people of color that didn't exist in the past. And we also, on a regular basis, we have conversations with our leadership at Trinity once a week on Thursdays. And it is not by happenstance or coincidence that our CEO reminds us that he expects us to, as we hire new leaders, to hire leaders that, again, are reflective of the communities that we serve. So it's a great company to work for, and because they sort of put their money where their mouth is, if you will. And to Moo's point, I mean, there is no ROI, but I would argue that, you know, when you have leaders and colleagues that reflect the communities, you get a better outcome. That's a fact, right? So if you look at Black babies and Black adults who are cared for by Black clinicians, their lifespan is longer. And that's a total different conversation as to why, but that's the ROI. And the leadership at Trinity Health understands that. And so they've embraced diversity, equity, and inclusion. I would argue probably stronger than any other healthcare system in the United States of America. So proud to be a part of the team.
Thank you for sharing that, Reggie. Dev, go ahead.
Yeah, you know, this is, again, to Moo's point, this is inspiring. And I figured the three of us have got to find a way to continue this dialogue in some capacity. For us, this is not about a moment, it's a movement. And in fact, in some ways, we have rebranded our approach to DEI under this idea from moment to movement. And to create a diverse, safe, inclusive environment really requires having those uncomfortable conversations. And we're finding and we're empowering individuals, leadership at all levels, to really have those conversations and listen and find a way to really understand what people are saying. And it is remarkable what you uncover. First of all, you make assumptions and you realize your assumptions were completely false. You uncover things that maybe you would have assumed might not be the case that in fact are the case. And then you have to be prepared to do something about it. And I'm fortunate to be a part of an organization where leadership at all levels has embraced this. We have a school of medicine that has embraced it in the same way that our physician practice has, in the same way that our health system has. And I'm excited to see what we're able to accomplish by understanding what exactly is happening in our organization. And then getting to this ROI issue, it is not going to be a financial ROI. Moo, you're exactly right. It's this ROI of who do you want to be? Who do you need to be? And are you there? And you know what? It's like a lot of other ROIs. It might not turn. It's not going to turn instantly, but it's an investment. And we are prepared to make that investment.
I really appreciate the comments, especially around the uncomfortable conversations, where it feels like to make this change broad across the healthcare system, there's going to be have to be a lot of folks having a lot of uncomfortable conversations. I'm wondering if you can just talk a little bit more about that, about how you approach those kinds of conversations, how you enter those kinds of conversations when maybe you are anticipating one might not go so well. How do you gear up for those?
Yeah, it will definitely takes a little bit of understanding and training on the part of the individuals who are having those conversations. You can't go in and assume the skill sets that you've had to have difficult conversations in the past are going to necessarily translate to future conversations. But it's also creating an environment where individuals don't need to be asked, but they feel able and capable and willing to tell. So again, we're part of the School of Medicine. We're very proud of the diversity of our faculty. But not too long ago, several of our minority faculty, African-American faculty, really kind of outlined how it is to be different at a world-class institution and to be a minority. And it was really eye-opening that you cannot make assumptions that because, well, everybody is a physician, everybody is a doctor, or everybody is a nurse, that's not going to apply. So part of it is having that welcoming environment and being prepared to be able to address those things that come up that are uncomfortable.
Appreciate that, Dev. I Time has flown by here, gentlemen. It really has been an inspiring conversation, and I feel very lucky to be a part of it. So I'm going to close with two questions. I'm not going to ask them at the same time, but I think we've got time for two. I'd love it if each of you could hit on them. The first of those two questions I want to ask is, I think there's probably a lot of folks out there who want to get started, who really want to start making a difference here, and maybe haven't gotten as far or taken the first steps necessary. So the first question I want to ask here as we close is for hospital leaders who are out there watching this right now and that want to make their care more equitable and accessible. What's a good first step? How can they get started? Moo, perhaps we'd start with you.
Yeah, thanks. I appreciate your starting with me. I was hoping to get the other individuals to start so I could learn a little bit, but I'll tell you what we sort of did. I think there are two things, and Dev hit on it. One is conversations. Now, obviously, you asked how you do it very carefully, right? I mean, you have to create environments where these conversations can happen that is safe, and where people feel like there are no repercussions and no consequences to saying things that they believe. Obviously, you got to be make sure you're professional and make sure you're not hurting people's feelings, but they still have to be safe to say those things. So creating opportunities around your organization to have those safe conversations is I think, one of the first steps. I think the other absolute first step is, if you are a leader and you want to figure out how to do this, is you have to say you're going to do this. So one of my first steps was to declare, we're going to do this. And then I went to the board and presented a policy to the board that they then voted and adopted. Now, once it's at the board level and at the CEO level, there's an obligation for the organization to go ahead and put that forward. Maybe the last thing that you may want to think of is making sure that every leader in your organization has on their, whether you're doing incentive or evaluation, has it on there. If it's not on there, if they're not measured, if they're not held accountable, people will tend to ignore it. So, you might put margin, you might put profitability, you might put revenue on people's sort of incentive plans or on their evaluations, but you got to put diversity, equity, and inclusion metrics and responsibilities and accountability. So I think those three things are the best way to start. And then you got to lean on people to help you do the work, because if you're doing it all, there's going to be a huge burden that you can't lift on your own.
Appreciate that, Moo. Jumping into the fray there and starting us off on this one. Thank you. Dev, why don't you go next?
I think for any leader, you have to ask yourself, why do you want to do this? And if your answer is anything other than because it is the right thing to do, I think you need to re-ask yourself, why are you doing this? Because this is the right thing to do. With that in mind, there may be pockets of your hospital or health system that have done this sort of work already. So understanding what your organization has already done is really important. And where that really plays out is we're getting signals from pockets of our community where they are also getting burdened with inquiry of individuals who want to find a way to engage the community and find a way to get involved. And it can feel like parts of the organization are tripping over one another to figure out how to solve the problem. So doing your own internal landscape analysis is important. And then having some structure when you're reaching out to the community, again, to not overburden the community with a bunch of opportunities to be interested and so forth. Again, you don't want to find a way, or you don't want to create a way rather, that slows people down from their excitement and their enthusiasm around this. But being a little bit organized can probably get you better outcomes in the long term.
Appreciate that, Dev. Thank you so much. Reggie.
Yeah, I think those two gentlemen summed it up, but I piggyback on what what Dev had mentioned, and that is I'd advise such leaders to be prepared to unlearn what you were taught in undergrad and grad school and medical school, law school, business school, whatever the case is. Second, I would probably adopt the Deming way of doing things, that plan, do, check, and act approach. But the planning part is the most important, like any strategic development or process, but you can't do it alone because you're not smart enough to do it. And people have to accept that. It's a hard pill to swallow, but go to the community and ask the community how to teach you to help them to get through their tough times, right? This is what equity is about. And it doesn't just apply to the communities that we serve, but also applies to the clinicians community as well as the colleague community. And then once you have your strategy, don't implement it until you go back to those respective communities and ask them, did we get it right? So plan, do, and then you go back and check it, and you have to continuously make assessments to ensure, because things change regularly, right? To ensure that you're on the right track to better serve or mitigate the inequities that exist in all those communities.
Appreciate that, Reggie, and I also appreciate the use of the phrase "unlearn." I think there's definitely some unlearning we we need to do. I want to get to the second question now of the final two, so our final question, which is, it has been an incredibly challenging couple of years for obviously the pandemic, some serious and racial reckoning that's also been very important, but it's also a hopeful time, right? Because we're having these kinds of conversations. So to close, then, the question I'll ask is, when you think about the future of healthcare, what gives you a reason to hope? Reggie, let's start with you.
I think you answered my question for me. The fact that these conversations are now starting to take place is a great sign for the future. Now, let's be open and honest, right? So, if there's a silver lining in the pandemic, it was because of the illumination of the social influences of health. We call them influences of health at Trinity Health, because we believe that we can change. They're not determinants. We can influence them, right? Like disparities. But it was only because of that pandemic that we started looking at social justice and economics and social influences of health. And now that hopefully we're transitioning into an endemic, will the conversation continue? But as long as we have people like you, Brian, Beckers, we've got people like Moo and Dev who are doing what needs to be done, I am very hopeful. But we have to maintain our tenacity to have this in the forefront of all of our plannings and all of our conversations. Otherwise, the next pandemic, we'll find the very vulnerable communities that we have been ignoring for many, many years are going to be the very hot spots, just as they were in this pandemic, that influences negatively the entire globe from an infectious disease process. So very hopeful. Thank you guys for your leadership and having the audacity to have this conversation. Much appreciated.
Yeah, Reggie. Point taken too about having to keep the tenacity up. Can't let the momentum fall away from it. So I appreciate you being here. Dev, why don't you go next?
Yeah, absolutely. This idea of how do you keep things sustainable? What gives me hope is that being a part of a medical school, as well as even an undergraduate program, we're starting to see individuals who are choosing medicine as a career wanting to build careers around the very things we've been talking about for the last hour. So it's not just the system that's looking to redesign, it's really those individuals who want to be a part of the future system. And that gives me hope. This idea that this isn't a sustainability exercise at an operational level, but it's truly redesigning healthcare, not only the way we deliver it, but then who becomes a part of it.
Excellent. Thank you, Dev. I really appreciate you being here as well. And Moo, we'll close with you.
Yeah, first I want to thank you, Brian, and also, Scott Becker, right? I mean, you guys are the reason that we have this platform. That just having the platform makes me hopeful. It gives me opportunity to meet with people I wouldn't normally meet with or wouldn't get an opportunity to meet with. I think what actually makes me hopeful, other than that, is two things. One is the idea that everybody wants to reimagine healthcare. I think that by definition should make us super hopeful, right? I mean, it's happened in other industries, but we've been a little slow because we don't want to change. But now everybody wants to reimagine it. Everybody wants to do it differently. Everybody wants to line it up differently. They want to be the Amazon or the Uber of healthcare. And I think that's really, really a cool time to be in healthcare. And I say, lastly, the next generation is what it makes me hopeful. I won't put my age out there, but I think that healthcare has been sort of an old, sort of slow entity or sort of animal. And I think the new generation doesn't want to engage with healthcare and with each other the way that we traditionally have. And so I think that makes me hopeful. And every time I'm sitting next to my daughter and she texts me and I'm like, why'd you text me? I'm right here. It makes me realize that the way we communicate and the way we engage is really, it's time to change. And so that reimagining, that next gen, that hopeful, having the conversations, being here with you guys, I'm ready to go, run 5 miles and figure this all out today. So thank you for having me.
Thank you for being here, all of you. Thank you, Moo. Thank you, Dev. Thank you, Reggie. I said it earlier, but it really was a pleasure to be a part of this. Thanks everyone for attending as well and watching. And we hope to continue to be a platform for these types of conversations. So thank you all.